Okay, so next we will hear from Dr. Christine McMahon talking about AML, MDS, and transplant.
Hi everyone. Can you guys hear me okay? Thanks everyone for coming today. For my disclosures. And so today I'm going to be focusing on updates from ASH and AML, as well as some MDS and transplant updates. And it turned out that I think most of my, or I think all of them actually involve venetoclax-based regimens. So the first study I wanted to highlight today was a plenary presentation at ASH, which was really exciting. It was presented by Amir Fathi from MGH, and it was focused on the results from the Paradigm study, which was a phase 2 randomized trial of azacitidine and venetoclax versus conventional induction therapy in patients with newly diagnosed AML who were fit. So induction chemotherapy with regimens such as 7+3 or other intensive induction regimens have been the standard of care for fit patients for over 50 years. There have been incremental improvements with things like adding FLT3 inhibitors or adding gemtuzumab for subsets of patients, but intensive chemotherapy has remained the backbone of therapy for fit patients. So previously, Dan Pollier here led a study at 2 institutions that looked at venetoclax and azacitidine for younger patients with newly diagnosed AML. The study initially only included patients who were adverse risk by the ELN criteria, subsequently included intermediate risk patients as well. And for the 36 patients who were treated on our study, the overall response rate was 69%. Lots of these patients went on to transplant, and kind of survival rates looked quite promising. When compared with historic controls who had received intensive chemotherapy, overall response rates were similar to better in patients who got ven-aza compared to 7+3. Lots of patients were bridged to transplant. Survival rates were really good. And the patients who got ven-aza had fewer transfusions, fewer infectious complications, and less time in the hospital. So this study showed kind of safety, feasibility, and ability to kind of give a less toxic regimen to patients with newly diagnosed AML who are fit, who are importantly patients who are going to need transplants in the future. So the Paradigm study then was a phase 2 randomized trial that included patients with newly diagnosed AML who were adults who did not have favorable risk disease. So they excluded patients with core binding factor rearrangements or NPM1 mutations because if they were age under 60, because those are people who could potentially be cured with just intensive chemotherapy without a transplant. They also excluded patients with FLT3 mutations who we know benefit from FLT3 inhibitors. Patients who enrolled were randomized 1-to-1 to either 7+3 or Vyxeos for those randomized to the intensive chemotherapy arm or to azacitidine and venetoclax. And then patients, once they achieved a response, could proceed with transplant at any time after that. The primary endpoint was event-free survival, and then a bunch of secondary endpoints, including response rates, survival, and things like quality of life metrics and toxicity. The study ended up including 172 patients who were treated, and the median follow-up time at the time of presentation was about 22 months. Overall, patients were pretty well balanced in terms of their baseline characteristics such as age, ELN risk, and mutations that were present. Overall, the patient, in terms of safety, the patients who were treated with Ven/Aza had significantly fewer grade 3 or greater infection and bleeding events, and they also had significantly lower 60-day mortality rates, so 0% in the Ven/Aza arm versus 4.7% in the intensive chemotherapy arm. Overall response rates were higher in the patients who were treated with Ven/Aza, and composite complete remission rates were also higher. Full CR rates were not significantly different between the two arms. The median event-free survival was significantly improved in the patients treated with Ven/Aza compared to intensive chemo. So Ven/Aza is shown in orange here. There was not a significant difference in overall survival, but of note, when they looked at patients who did not respond to their initial treatment or had relapsed disease, there were quite a few patients who went on to receive the opposite therapy. And so there was sort of unintentional crossover later, which may have contributed to why there wasn't an overall survival difference. So overall, the study kind of showed that Aza/Ven improves event-free survival for this patient population, so primarily intermediate and adverse risk patients with AML, and also led to high rates of response and frequently patients were able to successfully go on to stem cell transplants. So this slide is just showing kind of our current approach for our newly diagnosed patients here at the University of Colorado when taking the results of these recent studies into account. Of course, we always consider patients for trials when we have ones that are good options for them open. But otherwise, we kind of look to see, are they when we have a newly diagnosed fit patient, are they someone who could potentially be cured with intensive induction chemotherapy? So are they favorable risk by ELN criteria? If so, then our preference would be to give them intensive induction chemotherapy. If not, then we would also look to say, do they have monocytic disease, a FLT3 mutation where we know intensive chemo plus a FLT3 inhibitor patients do well, or do they have a KMT2A rearrangement? All of these are reasons we may prefer intensive induction chemotherapy, but for the rest of our younger fit patients, Ven/Aza is a very good first-line option for many of them. Next, I wanted to highlight a study that was looking at subgroup analyses from the phase 3 Verona trial. So the overall results had kind of previously been presented, I think, at SOHO last fall. But this presentation kind of showed some of the important subgroup analyses from the study. So this was a phase 3 trial for patients with higher risk MDS, and it looked at Ven/Aza versus azacitidine with placebo. Included patients with previously untreated higher risk MDS. So they had to have an IPSS-R score greater than 3, and randomized them to receive Ven/Aza or placebo Aza. And of note, the venetoclax duration was days 1 through 14 due to toxicity seen with longer courses of venetoclax in prior studies. The primary endpoint was overall survival, but key secondary endpoints included this modified overall response, so patients who got a CR/PR or marrow CR, meaning cleared blasts, and then other things like hematologic improvement. Baseline characteristics overall were, well balanced between the groups. This was an older patient population, as would be expected for MDS. And it was wide variety of marrow blast percentages at baseline, but about over 40% of patients actually had between 10 and 20% marrowblast, so what we would call a kind of MDS AML by the ICC. And there were quite a few patients who had TP53 mutations, slightly more in the Ven-Aza group, so 24% in Ven-Aza versus 18% in placebo-Aza. So there was no significant difference in overall survival between the two groups. However, patients who received Ven-Aza did have significant improvement in modified overall response, so 76% versus 57%. And this slide is then looking at subgroups for patients and looking specifically at the modified overall response subgroup analyses for that. And you can see that, many of the subgroups or most of the subgroups looked like kind of Ven-Aza was favored. This was particularly true for patients who were less than 75 years old, had higher marrowblast percentages, so between 10 and 20% in particular, who were very high risk by the IPSS-R, and those patients who had RUNX1 mutations. And then this is the subgroup analysis looking at overall survival. So if you recall, overall survival, there was not a significant overall difference between the two groups. But again, when you look at subgroup analyses, it's not quite as dramatic here, but you can still see kind of more of a trend towards benefit for patients who are less than 75, who have higher marrowblast percentages, and who were either high or very high risk by the IPSS-R. Overall safety with Ven-Aza was fine. There have been concerns these patients would have a lot more cytopenias, and they had maybe a little bit more, but it was manageable. There wasn't really a significant difference in kind of, really serious adverse events between the two groups. So overall, Ven-Aza did not show improvement in overall survival for all comers with higher risk MDS treated with Ven-Aza compared to single agent azacitidine. However, patients who got Ven-Aza did have higher rates of modified overall response, which is particularly important for transplant programs like ours that prefer blasts to be less than 5% when patients are proceeding with transplant, so important for transplant candidates. And then also showed kind of trending towards more benefit with Ven-Aza for patients who were younger, had higher marrowblasts, were either high or very high risk IPSS-R compared to intermediate risk, and then those who had specific mutations. And so, even though it was disappointing, kind of the overall study was negative, there are clearly still quite a few patients who seem to benefit from Ven-Aza with higher risk MDS. There were also quite a few updates from ASH on triplets with HMA and venetoclax regimens. I'm going to highlight two of them very briefly, but there were too many to kind of capture all today. I did want to show this update from the MD Anderson study looking at revumenib, oral decitabine, and venetoclax, and called SAVE study, so all oral regimen. The study is for patients, since it included a menin inhibitor for patients who had a KMT2A rearrangement or an NPM1 mutation or a NUP98 rearrangement. And for the newly diagnosed patients, they had to not be eligible for intensive chemotherapy. Patients were treated with this triplet regimen as shown here. And, adverse events overall quite manageable. They did report differentiation syndrome in a not insignificant proportion of patients, but it is a 10% grade 3, but no higher rates of differentiation syndrome. Patients were able to continue on the revumenib. Nobody had to hold it because of this, and it was kind of well managed with standard steroids and stuff like that. Also pretty high rates of QTC prolongation, 43%, which is a known side effect with revumenib, but none of those were grade 3 or higher. So again, very manageable. And I just wanted to highlight here, so overall response rates, overall were very high, 86%. There were only 7 patients that had KMT2A rearrangements, but of those, 86% responded, which when we've looked at kind of retrospectively at KMT2A rearrangements who are patients who are treated with Ven/Aza without a menin inhibitor, their response rates are well under 50%, more like 30%. And so this looked really promising, even though there's a limited number of patients. And so just kind of wanted to highlight, there's a lot of ongoing and planned trials looking at triplet combinations with menin inhibitors. And then this other triplet I wanted to highlight is a drug called PVEC that was studied with venetoclax and azacitidine. So PVEC is an antibody drug conjugate that targets CD123, which is expressed by most cases of AML. And this study was looking at the Ven/Aza PVEC triplet. And here we're going to focus in this presentation, they focused on patients who had newly diagnosed AML and were unfit for traditional intensive chemotherapy. And overall responses looked promising, so 80% CR/CRI rate, only 49 patients, so hard to say just based on this if it would be better than Ven/Aza alone, but looked promising. And I don't have all the safety slides in here because I didn't have space, but looks safe. They've had quite a few patients with quite durable responses, and so there is a randomized phase 3 trial planned, comparing this triplet to Ven/Aza. And then the last study I wanted to highlight today with all of these Ven/Aza presentations, with more younger and more fit patients receiving Ven/Aza, how do these patients do when they go on to transplant, which is what everyone with adverse risk and most intermediate risk patients need for long-term survival. So this was a study from Hopkins looking at patients who were treated, who had AML and were treated with either HMA venetoclax or intensive chemotherapy, and then went on to have a stem cell transplant. There have been other retrospective studies that have looked at this question, but they were sort of limited just because patients had all types of different conditioning regimens and all of that. And so they tried to kind of choose a uniform population of patients who got the same kind of conditioning and GVHD prophylaxis for their transplants. So this study included adults who had AML and who were undergoing their first transplant in first remission, who all had the same conditioning and GVH prophylaxis that included post-transplant Cytoxan. And patients had to have gotten either intensive chemotherapy or HMA venetoclax as their initial treatment. The primary endpoint was overall survival, and then they also looked at a bunch of kind of relapse incidences, non-relapsed mortality, overall survival, and GVHD incidence, as well as other secondary endpoints. Looking at the kind of patient characteristics for the study, overall, the patients who received HMA and venetoclax were older, so median age 69 versus 54, as would be expected, but otherwise kind of pretty well balanced. Um, the other thing that was different in the HMA venetoclax group is those patients were more likely to have secondary AML, which is generally kind of a higher risk situation, also more likely to have TP53 mutations, and were more likely to be MRD positive going into their stem cell transplant. Despite all of these differences, once they adjusted for age, there was no significant difference in overall survival between the two groups. You can see there's sort of a trend. So the HMA venetoclax group is shown in orange, intensive chemo group is shown in blue. The blue line's a little higher in terms of overall survival, but there was not any significant difference on statistical analysis. 2-year overall survival was similar. There was also no significant difference in post-transplant relapses or in non-relapse mortality between the two groups. The incidence of GVHD was similar between the two groups, both acute and chronic. And so overall kind of showed that post-transplant outcomes are similar regardless of how patients are treated initially, which is always kind of been our approach for years has been, as long as they're in remission or doing, responded after Veneza, we would anticipate them to do just as well after transplant. But it's nice to have a bigger study, bigger cohort of patients to kind of answer this question. And then the other thing that's interesting, which I know Dr. Gutman here has seen previously, or our group here has seen previously, but in general, for patients getting intensive chemotherapy, there's a lot of data saying that MRD status pre-transplant is really important for outcomes post-transplant. Patients who get intensive chemo and are MRD positive don't tend to do quite as well post-transplant. But in this study, a lot of the HMA venetoclax patients were MRD positive going into their transplant, and they did just as well after transplant, raising the question as to whether the MRD has the same prognostic utility for those patients. So to summarize, fitness is no longer the primary determinant of initial therapy for patients with newly diagnosed AML. Disease biology is most important. There are patients with high-risk MDS who benefit from HMA venetoclax despite the negative Verona survival in the outcomes in the Verona study. Lots of ongoing triplet studies, but definitely for patients who are getting Veneza, thinking about adding triplet targeted therapies for patients with specific mutations is important. And then post-transplant outcomes reassuringly are similar regardless of whether patients are treated with intensive induction or HMA-Ven. Thank you for listening, and I think maybe Gemlin and I both take questions now.